It's kind of the end of a long case. We just sort of kind of stick it on there, and okay, we're good. And so, so I think as soon as the patient's able to participate in education, I would say go for it. I've never had a problem with someone changing a wafer too soon. That's fine.
And so preoperatively, do you discuss with the patients the overuse of narcotics and how it's going to affect them adversely?
Yeah, I tell them a couple of things. My standard lines are, one, I tell them the less narcotics you take, the more you're out of bed, the faster you're going to feel better and go home. The other thing I tell them is narcotics are kind of a double-edged sword. If you have horrible pain and you don't take any, then you're lying in bed not doing anything, and that's not good. If you take too many narcotics, you're lying in bed not doing anything, and that's not good. So there's kind of a midpoint balance where you're a little uncomfortable, but you're functioning. That's where you're going to be after surgery, and that's where you want to be at, and I think kind of repeating that a lot and educating them and making that the understanding, goes a long way.
I have one more question.
Yeah, go for it.
So the stoma.
Mm-hmm.
Stoma assessment in and of itself, when we're looking at stomas for color and all the variables, what do you want us to do if we do start to see it go dusky, or is there something that we can just immediately call you, or is there a position that is there a magic something that we need to know?
Usually not. No, I mean, usually stomas. It's rare that we'll have a stoma that will just die and need to be revised. I mean, it does happen, but it's uncommon. Usually stomas will, in some instances, especially with obese, which is an increasing problem, they will get edematous and swollen, and they'll start to turn kind of purple or dusky. It's something to be aware of, and it's something we keep an eye on. I think the alarm bells would be if you see a stoma progressively looking darker and darker by the hour. Usually, anecdotally, when stomas die, they do it pretty dramatically. Like, dead bowel, it looks like dead bowel, and it doesn't, it doesn't gradually die. It's out. And so I think that as far as assessment goes, if you're seeing it progression, if you're seeing a stoma that's turning black, something like that, then it's something that we maybe need to take a look at closer. But, swelling and edema is pretty common, especially in the obese where, you've got a heavy abdominal wall, you're trying to tunnel a stoma through, an abdomen and muscles that's that thick. It can be hard to, get that to fit adequately. The other big thing is we look at is like skin separation, if the thing's pulling away. Again, not necessarily means we're going to revise it. Oftentimes we let these things just sort of pink up and heal on their own, but, again, things to keep an eye out for.
Are you doing surgeries with mesh involved near the stomas?
There's some data on that, that there's been some recent research into, so peristomal hernias are an issue, and technically speaking, every stoma is technically a hernia. It's a hole in your muscles, so every patient has a peristomal hernia in the technical sense. The question is how much is herniating in addition to what we wanted to herniate, basically. There's some data that's coming out increasingly that I've seen published on just prophylactically putting meshes in at the time you make a stoma to try to prevent this. I'm a little skeptical of what's the infection risk of sticking plastic in an infected field, but the data looks okay so far, so I don't know. Personally, I think I'm dragging my feet on that one, and I'm going to wait for more data to come out before I start doing it. On the other hand, people that were here fixing peristomal hernias, we absolutely are putting meshes in. But again, that's another advantage of robotics is that a lot of times with these peristomal hernias, rather than doing a stoma revision, we're able to just go in, minimally invasive, fix it from the inside, and we don't have to cut or revise their stoma, which makes them recover a lot faster because we don't remove any bowel. So we're not doing them prophylactically yet, but we are. You'll see meshes in the context of repairs. So. Yeah.
I can't tell you the last time I've seen an epidural placed for pain control. But there is an increased use of tap blocks, for sure. And there was just a conversation not a few days ago where both an anesthesiologist who states technically they can only tell the patient 12 hours of pain control, but observation-wise, there's many patients that receive up to 36 hours. And I was wondering what the floor has seen, what you have seen as far as the success of tap blocks.
Yeah, I think they have been successful. Again, with the ERAS approach, you're doing a lot of different things at once. It's usually going to be very hard to say, okay, this was the magic bullet, you know, and it probably wasn't for everyone. But anecdotally, yeah, I think they do a lot better. I think that, I also tend to think that pain is kind of a cumulative process, you know, that a patient who was pain-free for the first, 6 hours post-op is going to have less narcotic use than a patient that needed pain control for 6 hours, so I think that's part of it. So I think that those tap blocks do work. Epidurals, they are effective, but most of the data on epidurals has been in open surgery, basically. So, and what's happened is that it's becoming rare that you're doing a planned open operation on someone, and that would be the indication, I think, for an epidural. So we still do use them occasionally, but that's not a common surgery. You have to be doing an open operation and know you're doing an open operation far enough in advance that anesthesia can set up and do an epidural. The data on epidurals with laparoscopy isn't very good. It doesn't show a whole lot, so that's why we're doing tap blocks instead. But yeah, I think that that's a huge part of it. I think it helps a lot.
We're used to the world of orthopedics and doing blocks for orthopedics. Can you describe where the tap block goes and how it works?
It's a transversus abdominis puncture, I think is the P. I don't know the P's. But basically what they do is they use an ultrasound, they come out on the side of the abdomen, and they find there is the layer between the muscles of your abdominal wall. As you know, it's external like internal transversus. And so if you get in between the internal and the transversus, that's where all the nerves come in from the spine. And so they use an ultrasound to find that plane and then inject local anesthetic out here, and then they do one over here. So the theory behind it is that you are anesthetizing and numbing the entire abdominal wall from the nerves over. And so we of course still give local anesthetic at the wound, but you're always wondering how effective are we being in doing that? Are we getting all the nerves that are feeding it? What if the branches go out here? And so the idea is you're going to numb the entire abdominal wall, or at least give some analgesia there. And they use Marcaine, which is a longer acting local stuff. So that's the idea behind tap block. So, and that's a good point for floor nursing. So oftentimes what you'll see is they'll come out and they'll have a bunch of prep and maybe a little poke hole or two out on their side, and that's what it's from. Yeah, that's a good point. Other questions, thoughts? Well, good questions. Thank you for coming out this morning. And,
Appreciate
you're
your
all
time.
Yes.
Thank you.
tired at this point, but
Well, I appreciate you sharing your pain philosophy, because then I can reiterate it on the floor.
yeah,